Welcome to Expert Perspectives. My name is Paul Hesketh and I'm a medical oncologist at Lee Hospital and Medical Center. We'd like to review with you today some of the key findings and discussions relating to a satellite symposium that was held in conjunction with the annual meeting of the American Society of Clinical Oncology. The symposium was devoted to looking at advances in chemotherapy-induced nausea and vomiting treatment, new emerging strategies, and best treatment strategies. With me today are two faculty members from that symposium. We have Dr. Richard Gralla, who is from the Albert Einstein College of Medicine in New York City, and Dr. Matti Apro from the Clinique Genolier in Genolier, Switzerland. Our initial discussion was focused on the issues of developments in neuropharmacology and the neurophysiology of CINV. Dr. Gralla focused on this in his talk, and I would ask you, Dick, just to highlight some of the key points that you made relating to developments in neuropharmacology.
Thanks, Paul. Yeah, I think we really had a good discussion on many topics at the symposium, and one of the areas we wanted to review was the physiology involved in emesis, and this has been the basis of developing antiemetics for use in the clinic. We really have a very good understanding that began half a century ago with discoveries by Borison and McCarthy, looking at the areas in the GI tract and looking at areas in the brain that are important for emesis. We reviewed these and we looked at the main neurotransmitters that are involved. It is clear that we really have very targeted therapy for our major areas of treating emesis. We know that the serotonin antagonists, the pharmacology behind that, and the physiology is very well grounded. We know that the same thing is true for the NK1 receptor antagonist. While the steroids are very important, we used a lot of dexamethasone in this area. There, unfortunately, we don't have as much knowledge as what the true pathways are. But for all the rest, we know exactly how this should be coming about. We reviewed a lot of this. We know that the NK1 receptor antagonist must get into the brain to be effective, but that the serotonin antagonist can work just in the gut or in the brain, either way. Now, in looking at the results that we have, and seeing what the impact of good control is on quality of life and on so many areas, we recognize that we've done a particularly good job in controlling vomiting, and we've improved the control of nausea, but nausea continues to be the most difficult problem that we have. We're aware of the risk groups and that younger women are the top risk group that we have. We know of other factors that are there. We don't really understand why it is that it's more difficult to control emesis in women and in younger patients than older patients. But we're aware of these as two top factors among several that have to be considered. We don't precisely know why nausea is more of a problem than vomiting, but I think a lot of it could relate to earlier clinical observations, such as Sir Zachary Cope in the diagnosis of the acute abdomen said that first what you see is anorexia, then you see nausea, then you see vomiting. And a lot of people have said, does this mean that for vomiting there are just a few neurotransmitters that are involved that if you can block those, you can block vomiting? And that there may be more neurotransmitters that are involved with the concept of nausea. Again, these are all protective mechanisms that we have, and they're even more involved with appetite, for which you would die if you didn't have a stimulation to eat. And so one concept is that there are more neurotransmitters that are responsible for the control of nausea than there are for vomiting, and that when we block vomiting, we don't block all the neurotransmitters that may be important for nausea. And then a concept that some people have and that I agree with is that what we do is we get physiologic events like gastric stasis, salivation, etc., before we feel nausea, defined here as the feeling that you might vomit. And you have to reach this threshold before you sense nausea. And as that threshold rises, it then can reach a point where you then vomit. And what it may be is that our anti-emetic drugs, our anti-nausea drugs, or all work by suppressing nausea. And they may suppress nausea so far that you don't even perceive nausea, and that's a great result for us clinically. Or they may suppress nausea so that you don't vomit, but that you still have this feeling of nausea. If these things are related in that way, if nausea leads to vomiting, then clearly a logical endpoint going forward in new trials should be how much nausea do patients have. And we have a lot of trials that show that we fairly accurately can measure nausea. And of course the patient has to tell us, but that the visual analog scales that we've used are pretty good at this and pretty consistent. So from all this, we do understand more about the physiology of nausea and vomiting, and also it reveals what our biggest problems are. There are some pharmacology issues that are involved. We know that the serotonin antagonists really are well metabolized, have very few side effects, but they do have some, such as constipation and headache, that we need to look at. The NK1 receptor antagonists are remarkably free of side effects in themselves, and it may be because we're not really sure what that NK1 receptor is doing normally. If you block a beta adrenergic receptor, you know that you're going to have some normal physiologic events that have been suppressed. But that's not necessarily true with this NK1 for which substance P binds. However, there are drug-drug interactions. Not so many for the serotonin antagonists, but for most of the NK1 receptor antagonists are metabolized through the 3A4 pathway of cytochrome P450. And so are 1/3 of our drugs, especially oral drugs, are metabolized this way. So whereas this is not so much of a problem as long as you're aware of it clinically, it's interesting that one of the newer agents that's being developed, rolapitant, that's still an investigational drug, does not appear to have any impact on this pathway. So it's kind of interesting that this understanding of pharmacology has led to the development of a drug that is interesting in that way. So I think that when I finish my presentation, I hope that that set the table for discussion of some of the newer agents and some of the issues that involve all of us in our daily practice of medical oncology.
Yeah, I think your discussion really did set the table appropriately in terms of telling us that we've made very significant strides in terms of development of new agents, understanding the mechanisms involved, particularly serotonin antagonists and the neurokinin-1 receptor antagonists. But I think one of the big challenges that Dr. Opro dealt with in his talk is the fact that even if we have effective tools, if those effective tools and agents are not utilized appropriately, we're not going to achieve what we would like to in terms of optimal antiemetic outcome. So Dr. Opro, maybe you can talk a little bit about some of the issues that you dealt with relating to adherence to guidelines and trying to improve control by getting both providers and patients to be able to adhere to the evidence-based guidelines.
Yeah, Paul, I think that with this basis of the physiology that explains the development of these drugs and the way we develop them, it's very simple. We have 3 classes of drugs, basically, with the corticosteroids. We have the FIH receptor antagonist and NK1 receptor antagonist. The question is, do you use all 3 of them, or do you use a combination of the 5H receptor antagonists and corticosteroids? So there are guidelines that help us for that. We divide chemotherapy basically today in 4 different groups: highly metagenic, i.e. without protection, almost every patient will have nausea and vomiting. Then we have the moderately metagenic, which is a group of 30% risk to 90% risk, a large group. And this is something that we really have to tackle nowadays because there are some interesting data there. And then we have the less metagenic chemotherapies. We know that for highly metagenic, where we have now put also the combination in female patients of anthracyclines and cyclophosphamide, we should be using the 3 drugs. Moderately metagenic, The guidelines today say use 2, but some guidelines already say, well, in some situations you might want to use 3, even though the studies were not prospectively done with enough numbers. But when you put all the data together, and I showed some data that has been put together by Dr. Karen Jordan, looking mainly at studies that have been done in Asia, excellent data coming from our colleagues in Asia, that show that for carboplatin, actually the 3-drug combination probably is the best way to go. And Dr. Gralla with Dr. Rappaport already had done a retrospective analysis with aprepitant that showed that indeed in that particular setting there was a clear advantage. And they were criticized and said, oh, it's retrospective. But well, the data were the data. The data had been prospectively collected. And now with the 2 new agents, one that has been now accepted by FDA and EMA, which is the combination of netipitant and palonosetron called NEPA and commercial name Kinzo. We also have data that Dr. Jordan presented here at the ASCO meeting, show that indeed for carboplatin, this is probably the way to go. And I guess Dick and Paul, we are all involved in the MASC ESMO Guidelines Committee. Would we guess that we are going to change our guidelines?
Well, I think it's interesting because an additional piece of data that we actually presented at ASCO at this meeting related to the new agent rolapitant. In one of their key phase 3 trials with over 1,300 patients, looking at what was called moderately metagenic chemotherapy, half of those patients were receiving anthracyclines and cyclophosphamide. The other half, however, were receiving non-AC MEC. And within that group, 401 patients actually were receiving carboplatin-based regimens. And so to date, that perhaps is the biggest subset from any study to date looking at the use of an NK1 receptor antagonist in addition to a serotonin antagonist and a steroid. And clearly the data was pretty compelling. Again, even though retrospective subset analysis, the data pretty compellingly showed a significant, both I think clinical and statistically significant advantage for the addition of an NK1 receptor antagonist with magnitudes of difference in terms of complete response on the order of 15%. So I think that my own bias for our upcoming consensus conferences where guidelines are going to be updated would suggest that that perhaps is one of the areas that needs the most updating, because I think there's been an emerging body of data that you've cited in your talk and also data presented at this ASCO meeting this year that would strongly argue for the addition of a neurokinin-1 receptor antagonist in that setting. And again, perhaps not prospective trials that focus just on carboplatin, but I think when you see a weight of evidence that's emerged from the various different studies that have been done to date, it looks pretty compelling. Dr. Gralla, what's your perspective?
You know, Paul, your data that you presented this time and that magnitude of difference of the absolute benefit seems to vary between 10 and 18%. And that's the same magnitude of benefit, more or less, that we saw with cisplatin when you added 3 drugs versus 2. I think that is very compelling. And when you look at all the data from the Asian studies that you point out, from the subset analysis of the rolapitant data, Matty pointed to the subset analysis that we had done from a study that Bernardo Rappaport published, they're all extremely consistent. It gives us a database that is one of the largest of for any drug that we know of, that is for carboplatin. I think that carboplatin is, the problems with carboplatin are underappreciated by many of us, and so this could give a nice benefit. After all, our real overall goal is to get to 100% control for patients, for every patient, for every cycle. We're not there, but this is the way we move in that direction. We have done a quality improvement project in my own institution, just sort of looking experientially to see where we are, and there is probably a 30 to 40% emesis rate for people getting carboplatin in our institution, which is, and they're generally getting 2 drugs, which is exactly what the studies would show, and we find that to be unacceptable. The guideline groups in the past have said anything that's more than a 10% difference improvement should affect guidelines. So I think we'll have a nice discussion in the guideline groups, and my prediction would be that the guideline groups are going to be influenced by these data.
So we shall see. The problem that I also discussed is that we have excellent guidelines that have been put forward by NCCN, by ASCO, by the MASC ESMO group, and also nationally many groups have put their guidelines out based on the evidence available. But then the reality is, and there are 3 recent studies in Asia, in the US, and in Europe that show that actually clinicians don't apply the guidelines. The clinicians don't apply the guidelines, and one analysis that we did in Europe shows that patients treated according to guidelines have exactly this benefit that Dick was alluding to, 10% difference in improvement in control of nausea and vomiting, showing that the guidelines have been established really on the basis of data that should really bring a benefit. So the question is, why aren't our colleagues applying the guidelines? They are not very complicated. What should we do for them to apply guidelines? In some countries throughout the world, there is an issue with regulatory authorities that have not always accepted some of the new agents, have put some restraints on the use of these agents. But in countries where there are no restraints, we nevertheless observe that the guidelines are not followed. When you discuss with some of our colleagues, they will say, well, actually, my patients are fine. They don't have a problem. And this has been very nicely reviewed in a couple of papers. Patients actually don't want to report problems back. They believe that chemotherapy-induced nausea and vomiting is normal. If it's not too bad, they don't want to discuss that. They want to go ahead with their treatment. They're afraid that you might want to change the treatment because of that. Whereas they should report it to us so that in those cases where they were not receiving the triple combination, we can use the triple combination. There can also be other reasons, and one of the reasons is that the patients, for some regimens, have to use pills on the 2nd and the 3rd day, either the corticosteroids or use the N-chemo receptor antagonist that is given orally, and patients don't like to take pills. They're already taking quite a few pills for quite a few of our patients. So one of the advantages of the new drugs that are coming forward is that they are given on day 1. You give them on day 1, and you might or might not want to use corticosteroids in the next few days, depending on the specific setting of the patients. And that might improve adherence of the patients also to the guidelines.
So I think that all is so important. It's how do we make it easy for patients and for physicians and nurses to make sure that the guidelines are followed. And one way is, as Matti has said, to simply have everything given right up front at the time the chemo's being done. The combination of nitupetant and palonosetron that you mentioned, the NEPA or Kinzio, it's one capsule that is taken, and that's it except for the corticosteroid. And nothing more during the entire time other than whether or not the corticosteroid is given. Everybody agrees on day 1 the corticosteroid ought to be given, but that's easy as can be. And then the other thing that is of interest is, can we link the administration of the antiemetics and the proper guideline antiemetics with the ordering of the chemotherapy? And a lot of places have done that through electronic medical records, electronic ordering, or it can be done in paper. You just have a checkbox, guideline recommended antiemetics. And people say, well, what prescriptions do I write for the patient once they leave? There is evidence that if you're giving steroids, especially on day 1, which most of us certainly agree with, that you don't need to give further 5-HT3 antagonists. And so that's easy. And so it only turns out that the only prescription patients might need is whether or not they need corticosteroids. And in a paper that you wrote, Matti, you gave moderately emetic patients with breast cancer largely receiving anthracycline cyclophosphamide in the Annals of Oncology last year. And you showed that basically they took everything on day 1 with the nitupetant palonosetron plus steroid, and that was it. And the control was quite remarkable. And so there's nothing easier in following that. The Rolapitant data that you presented, Paul, have been developed with the single-day treatment. And there is fosaprepitant data with single-day treatment, and our colleague from Italy, Dr. Roila, has shown some aprepitant day one data that looks pretty impressive. So even the regimens that were pretty simple to start with have become so easy for patients to adhere to. And what we need to do is get ourselves as prescribing physicians into the right role on this. And Matti, you also showed rather remarkably that when you poll European and US oncologists, that we believe that we're adhering to guidelines twice as often as we actually are. So we need a little extra help to be sure that we are, and I think the electronic ordering to be easy that way, or a checkbox, can make it so that patients don't miss out.
Right. I think the other thing that's been shown quite clearly, perhaps best by work by Stephen Grunberg, is that there really is a disconnect between what the provider believes the expectations are going to be in terms of outcome and what the actual outcome is from the patient perspective. And so I think that clearly, as you mentioned, Matti, unless the patients are specifically asked when they are seen as to what happened, they're very unlikely to bring it up spontaneously for the reasons that you cited. So I think to the greater extent that we educate the providers that, yes, your patients do have this as a problem, if you ask, you will realize that. Then I think with that greater understanding, there'll perhaps be more interest in trying to adhere to the guidelines. I think one of the other things that we touched on last evening as well was trying to have tools to help in terms of increasing compliance. One thing obviously would be the use of the electronic medical record, but the other is a relatively low-tech but very simple tool that's been developed by the Multinational Association for Supportive Care in Cancer, and that's the MAT tool. So maybe you could just briefly comment on that, Dr.
Absolutely, Paul. The MASC, mascc.org, has a lot of tools, and a lot of our nurses in particular have been extremely interested in the MAT, which is under the anti-emetic portion of the MASC website. And there you can pull up the MASC anti-emetic assessment tool, which is a free download, which is available in multiple languages, and it's only 3 pages long. The first page is largely instructions, and it provides a nice quality improvement project, which again our nurses are using, a very easy way for the patient to communicate with the healthcare team to show that things are coming along well for the patient. And it even includes a spreadsheet so that you can even look at the patients who are getting certain type of treatment. It could be used in a research project looking prospectively as well. And it's even an app. The MAT is an app, and you can search for it for iPhones or for Android and do it in that way. It's very simple. It's right there for everybody to use.
Mm-hmm. All right. Well, I thank you both for your discussions today. I think we had a very interesting session. We had a very engaged audience last night with a lot of good questions.
Lots of questions, yeah.
And I think it was a very useful activity, and we are grateful that you're joining us today for expert perspectives. We hope that we've provided some useful insights to you in terms of some of the progress that's being made in controlling the problem of chemotherapy-induced nausea and vomiting. Thank you very much.